Hello, and welcome to Managing Orders with IMT OQM. This webinar was previously recorded on June 20th, 2017. We'll begin with a brief introduction to IMT. Here at IMT, we strive to be just one thing: identity solutions experts. And what that comes down to are three main focuses for our business. First, we focus on identity. We're niche-focused, creating solutions that solve identity challenges. We're innovative, we're agile, and we're constantly creating new solutions that revolve around master data management, entity resolution, and in general, figuring out the identity of your patients, customers, or citizens. Next, we have solutions. When it comes to solutions, we're focused primarily on healthcare, life sciences, e-government, insurance, and payers. The problem of identity branches across multiple industries. However, we found that for healthcare customers, this is an extremely acute issue. And so the solutions that we create tackle those situations head on, such as our OQM solution that we'll be talking about today. And finally, experts. IMT is recognized globally as one of the experts in IBM InfoSphere Master Data Management. We've attained gold level as a business partner of IBM's, and we've proven ourselves with over 100 projects successfully completed. We also create end-to-end solutions, extending the power and core capabilities of master data management, and we're committed to research and development, creating new solutions that further enhance the experience of our clients. At this point, let's go ahead and introduce today's panelists. First, we have Lisa Luikart, the Financial Systems Analyst at Cabell-Huntington Hospital in Huntington, West Virginia. Lisa brings over 18 years of healthcare experience. She started as a clinical researcher and has since moved into practice administration. In 2012, she joined Cabell-Huntington, where she works as a financial systems analyst. She's also responsible for coordinating several revenue cycle IT projects across the organization. We also have with us today Deanna Nole. Deanna has over 17 years in product management experience, 9 of those in healthcare and population health. She came from the Initiate and IBM teams where she focused on provider solutions, and Deanna joined IMT about a year and a half ago as the Director of Product Management. And with that, we'll turn things over to Deanna.
Great, thanks Tyson, and thanks everyone for attending our webinar today. I'm going to go ahead and kick us off today talking a bit about the challenges that exist in electronic orders and results exchange for lab tests and imaging orders. So in today's world, electronic ordering via EMRs is in use for most providers, and those providers can enter an order which can be sent directly to the lab or to an external site like an imaging center, and then typically the provider will wait for a result back, ideally to be sent back electronically. However, there are a number of obstacles that are preventing those orders from loading into those testing systems and somewhat inhibiting the value of the systems being in place in the electronic exchange. So a couple of those items are that the ordering system doesn't necessarily format, split, or combine orders in a way that each testing system requires. So let's say you have a single requisition with a number of orders in it. Those might need to be divided into individual transactions based on the receiving system's requirements. So it can vary based on the number of different lab or imaging systems that you're sending orders to. Ordering and fulfilling systems often will use different test and result codes to represent the same thing. So if you have an order for a basic metabolic panel, that's going to require some translation to the specific codes that the testing system needs in its order compendium. And the same issue is going to exist and impact routing result codes back to the ordering system, and they attempt to load against the patient's record. EMRs and lab systems know patients differently. They use their own identifiers and MRNs. So for the order to load against the correct patient account in the lab system MRN needs to be present on that order, and it most often is not. If an order arrives for a patient that's never visited the lab before, a new patient registration is going to need to occur. Today that's typically done manually. but it would be much more efficient and less prone to errors if it could be done automatically, especially when you already know information about that patient due to visits to other departments within the health network. And then lastly, when the test result is available, the test has been completed, some challenges remain to return those results to the provider's EMR and to have it linked back to the outstanding order. That can be due to mismatches in the patient identifiers or the provider identifiers as well, being able to make it back to the correct instance of the EMR. And so that can result in lost results that can take time to locate, or duplicate tests may need to be ordered again because the result can't be found. So I want to talk then about what the financial impact of these challenges can be. So let's say you have a provider here, and this provider sees 100 patients a week on average. And let's say 60% of those visits result in the creation of an order for a lab test or an X-ray or MRI blood test. Let's say 30% of those orders either are for a brand new patient that's never been to the lab or imaging center, let's say that the wrong patient ID is present on the order that arrives, order codes don't match, any number of the issues and challenges I just talked through on the previous slide, that order is not going to load. So the testing center staff can spend around 5 minutes an order registering that patient, looking up codes, manually entering the order into the system that was, sent electronically, but, didn't quite make it. So the cost of those manual efforts can really compound quickly when a lab or imaging center serves, say, 150 providers. You're looking at over $200,000 a year in unnecessary manual efforts for the lab and imaging staff. And on the provider practice side, it could cost a mid-sized practice $20,000 to $30,000 a year in efforts spent reordering tests, tracking down test results, and entering them against the patient's record. So we're going to get to Lisa's story here in just a minute, and she's going to give you a deep dive into how Cabell uses OQM to streamline orders and registrations for their lab and radiology orders. But first, I want to give you a quick overview of what OQM does, and then I'll hand it over. So OQM Manager is a flexible, rules-based workflow and integration solution that provides the routing, validation, and registrations you need to ensure that orders load and results flow back seamlessly without errors, unnecessary data entry on either side of the process. So the way that it works is that when a provider creates an order in EMR, it's sent to OQM. Then OQM is going to take that order, is going to facilitate the necessary processing for that order type, whether it be for lab or for radiology, whether it's a new order or cancellation, to make sure that it has what it needs to load into the lab or imaging system. So we will leverage the EMPI, and we work most often with IBM Initiate MDM to look up the patient MRN that's needed. We'll add any missing patient information that is in the EMPI that might be needed for medical necessity check or insurance validation. We will apply the necessary test codes that we have reference to in a code compendium, and does all the formatting needed by the receiving system, sends it, so that it can be delivered via HL7. So then the order will stay in a queue until the patient arrives for the test. So the testing center will locate the order in the order release dashboard that we'll get another look at in a little bit, and releases it to the test system. After the test is completed at the center or the lab, and the result is sent back to OQM, the result will be automatically routed back to the provider's EMR, and on the way back, we do all the same data validation and reconciliation services so that the result can automatically post against the original order. So OQM can be extended to support any number of order types and interfaces using standard HL7 transactions, and any workflows can also be customized based on system-specific needs. So with that kind of quick overview, I'm going to hand this off to Lisa, who's going to go to the next level on talking about their implementation and go through some really great information on the benefits they've seen using OQM. Lisa, or Tyson, you want to hand the ball to Lisa?
I have it. Thank you. So first of all, thank you guys for letting me share our story at Cabell with you. But first of all, let me tell you a little bit about ourselves. We're located in Huntington, West Virginia. We're located along the Ohio River Valley. We serve about 29 counties. We're about 30 minutes away from Ashland, Kentucky, and Ironton, Ohio. We are a 303-bed teaching hospital associated with the Marshall University School of Medicine. Marshall makes up about 75 to 80% of our business. The main campus of the hospital includes the Edwards Comprehensive Cancer Center, Hoops Family Children's Hospital and Marshall Health. We also have several outlying healthcare facilities and outreach facilities in the community. Okay. Now, as Deanna mentioned, there are several challenges to trying to share the information between all these systems. And this slide illustrates the most common data sources that we have for different entities. Cabell-Huntington Hospital and the Cancer Center use Affinity for its health information system, where all of our patient accounting and registration functions are housed. And Cabell's EHR system is Cerner, and we also have several ancillary systems, with Soft Lab and PACS being two of our biggest ones. The Cancer Center uses Varian for its EMR, and within Varian there's two arms. There's a medical oncology arm and a radiation oncology arm. Marshall Health uses GE Centricity for its HIS system, and Allscripts is its vendor for its clinical system. Now, in addition to having all these systems, we also have multiple interface engines that we have to address. And so that is a big challenge, trying to get through all the steps to get one order processed. Between Cabell and Marshall and the Cancer Center, we have multiple competing priorities. So that was a challenge for us when we looked at these projects. We've got different leadership in each area. Each leadership has their own priorities. And the staff for the project team cross all three areas. However, everyone at our institution has a day job in addition to their project work, so that was difficult to manage. The third thing we had to overcome was the order catalog alignment. So we had to make sure the compendiums that are housed in Allscripts or Varian match what we use in Cerner. And then fourthly, we had a huge resistance to change. When I joined Cabell in 2012, the average tenure of an employee was about 21 or more years, which is great for organizational stability. However, there was a lot of people thinking, well, this is the way we've always done things. Why should we have to do something different? If it works now, why do we have to change it? And finally, because we were working with multiple entities, we had to overcome some trust and acceptance of data from other facilities. Those were our biggest challenges into implementing OQM in our facilities. We had hoped to, we've had a lot of patient dissatisfaction. Because the hospital and the Cancer Center and Marshall Health coexist on the same campus, patients frequently left the room where they saw their physician, and they might walk down the hall to receive hospital-related services, or they had to walk over a little bit farther down the hallway to the hospital department itself. And so patients were getting frustrated. They were asked the same information at their physician's office that they were asked for the hospital registration. And sometimes they were being asked that within moments of each other for the different registration requirements for each facility. So the dual registration made the disconnect between the entities very obvious, and it did not make for a smooth patient experience at all. Cabell had a lot of processes in place to help streamline it for the patient. However, those processes created a tremendous amount of rework on the back end. So, for example, for our lab accounts, our lab specimen accounts, a process was used to quickly generate an account number so that services could be rendered and the results could be sent back to the providers. For our radiology accounts, we had a quick reg process, same thing. We quickly were able to assign an account number, render services, and send the results back. At the end of both of those processes, we had piles of paperwork that registration staff had to manually touch and update in order to make the accounts active, to allow the charges to drop, and to allow the claims to go out the door. That's a huge volume of claims that we were doing that with, a huge volume of registrations we were doing that with. And finally, we had an issue with missing orders. So frequently patients would show up and not know why they were there, or they had an order that had been updated since they got the piece of paper from their physician's office. So we had to spend a lot of time tracking down the correct orders from the physician's offices. That also caused a delay in patient care and is another frustration point for our facility. If we didn't have full accurate orders as well, we could not bill the charges. We wouldn't receive payment for those charges. So our first goal with these projects was to make sure we had the patient correctly identified across the whole continuum. The Marshall patient, named Lisa Luikart, was the same as the Cabell patient named Lisa Lowen. We wanted to make sure that we had the complete, signed, accurate orders sent all the way downstream. We definitely wanted to get the over-processing and inefficient workflows resolved. And finally, we wanted to make sure we had the correct results tied to the correct patient so that our providers can take the best care of our patients. We implemented the OQM projects in 3 phases. The very first thing we had to do was get MDM in place, and that's the Master Data Management Solution that Deanna was referring to earlier. This ensures that the patients across the continuum are linked correctly, that, again, that Mary Jones at Cabell, when she got married, she was recognized as Mary Smith now, and we know that they're the same person. This MDM also allows us to address discrepancies such as name changes, errors related to Ms. King, any birth or new patient, incorrect or limited data available at one of the registration points. So after we had MDM implemented, our data stewards from all departments working on making sure everybody's matched correctly, we need to really understand the processes behind the workflow for OQM. So we did a detailed workflow analysis with the super users, department leaders, our IMT solution architect, and the IT teams from all the entities. Once we did the workflow analysis, we also had to do a deep dive analysis for our ADT and order feeds. We had to make sure the data fields were mapped correctly between all the systems. The order compendiums were mapped. And then we had to really think about logic that we needed to develop that was custom to the way our accounts were handled. And for example, if we have a patient that has an insurance that's over a year old, Cabell chose to have those new registrations created with self-pay because insurance changes so much in our area. We would rather register the patient with self-pay rather than an incorrect insurance. That way we have time to correct that on the front end. If Marshall had an email for that patient and Cabell didn't, we could pull that one field forward so that our view of the patient is complete as well. And finally, after we did the workflow analysis and the mapping and the logic, and after thorough testing, we were able to deploy OQM for our lab specimens, and that's using the orders and registrations, and then radiology walk-in clinics. Okay, so our new workflow looks like this. It's a very much more streamlined process, and this is very similar to what Deanna mentioned earlier. Our orders are written, and specimens may be collected in the physician's office. The information automatically goes to OQM from the provider's EHR system. We validate the patient against MDM and the codes against the compendium. Specimens might be received in the lab, or the patient may present for services in our radiology department. And then OQM is used by the lab staff or the tech staff to identify the correct patient and determine which orders they want to be released. If the patient's never been in our system, OQM will automatically create the patient as well. Once the order is released and the registrations are created, information is sent to our registration quality vendor, and insurance is validated, or demographics are updated or verified, and medical necessity checks are completed. The orders go downstream through Cerner, through SoftLab, and then once the results are available, they are matched back to the patient based on the order ID. in addition to having that more streamlined workflow, we had some additional benefits by using OQM. So now we use OQM to send a copy of the order document, so it's a textual document that is sent to our Cerner system that allows staff to actually see what the order looked like, not just an electronic order. And then again, our orders are fed downstream to Cerner and to SoftLab. The coding solution, our computer-assisted coding solution, can recognize the textual order document that we've created through OQM and use that to help read the tests and the diagnosis codes on that account. So that aids in coding. And all those piles of paperwork that we had to process before, previously we were scanning them into the system after the account was updated. Now we no longer need to do that. We've eliminated mountains of paperwork. That's very exciting. What you're seeing right now is a sample of our actual OQM dashboard. It's a very user-friendly, very customizable tool. So the first thing I want to show you is this order type function. So all of our orders come into OQM with a way that we can categorize them. And so we can customize what the end user is seeing based on their order type. So for example, if I work in the lab, then we can only show lab orders because that's all I'm going to be fulfilling. Radiology has the same opportunity. We can show only rad orders to people who are performing rad tests. The second set box here gives us multiple ways to search for a patient. We can use the standard name, date of birth, social searches if we'd like. We can search by the ordering provider's MRN number, which is frequently available on the orders, on the electronic orders. This box allows us to select the right patient from a list of results that have been returned in the above search. And it also lets us choose what the order status is we want to see. Do we want to see only orders that are outstanding? Do we want to see orders that have been canceled or orders that have already been registered and passed downstream? So we have those options here. This lower or left-hand box shows the orders that are available, and I have mine filtered to outstanding. This shows the orders that are available to be released for this particular patient. In this box, we can see the provider, we can see the order date, the date that the provider wants the services to be done, in case they schedule a lab for 3 months out. We can see that information. We can see the test codes and the ordering location. OQM also has this nice logic in it that shows the test highlighted in yellow if it is still available. So if a provider has multiple tests on a requisition, then we would have multiple test codes here on the same line. But say we can only process part of that order, part of those would still be yellow, showing that we still can process those later, or we'll have some that are not highlighted to show that those have already been done. And finally, in this lower right-hand corner, this is where we confirm that we have the right test selected to process. We confirm the description. We select this release action. That release action is how we classify our accounts by service at Cabell. So if it is this particular lab test, we can call it a specimen account. Our radiology tests go to a rad account. That's how we organize them. Over to the left of that box, you'll see a service date. That lets us set the admit date on the account, and then we process it. And that's when OQM has done its work, an account number is assigned, and everything is sent downstream. So what you're looking at now is before we had OQM, the radiology process created these piles of paperwork. So every day, registration staff would do a quick reg. They would get all the documentation together, copies of demographics, insurance cards, copies of orders from the physician's EMR system. They would register the patient, put a face sheet on it, and send all this information back down to Cabell to finish updating the registrations, making sure insurance is valid, so on and so forth. So this is just a very small sample of the paperwork that they were receiving on a daily basis. Staff would have to work this paperwork pile to get them done between the regular patients, and the goal was to have all of these patients registered by the end of the month. And it cost a lot of overtime trying to process these counts. So once we had OQM implemented, we saw a lot of improvements. We were able to eliminate delays in registration, because now instead of being a registration that was stuck in a pending status or a quick status, we now had a full registration available to use for us. So we didn't have that big, long wait. As soon as the test was released from OQM, the registration was immediately available. Because we had all the data available to us electronically, the demographic information, we had the insurance information, we had the orders, we no longer needed those piles of paperwork. So all of that mountain of scanning was eliminated. We set our OQM system up so that the order had to be complete, and all those required elements had to be there. So once the order was complete, it was available to be passed downstream, which meant no more missing order. The CAC program was again able to read the textual documents of our order, so that aided in improving the times for coding, and then we were able to tie those back to the correct patient in the provider system. We had a lot of improvements with our process, and we were very impressed with this. We started going live in March of 2015. We had multiple small area go lives for our lab services, and that was to help make sure they were getting comfortable with OQM, make sure they were getting comfortable with new workflows, and start trusting data between the sources. We project about 28,000 registrations to be done for labs through OQM. This accounts for about 55% of the specimens that we process, and then 31% of the total labs that we process. The difference here is specimens are just the samples being submitted, and total labs include patients that are presenting to the hospital for blood draws. Previously, it took about 4 to 6 minutes to update the account once the paperwork was received from the performing department. And as I demonstrated with OQM, the process is nearly instantaneous for that account to be created. So with that, we expect to save about 2,300 hours a year, in a 12-month year, using the OQM processes for labs. Our orders are also available for improved coding, and we now are able to focus on an exception-based workflow rather than having to just churn through piles of paperwork to get that done. And we're running through it so fast that the attention to the quality and accuracy couldn't be given the attention that it deserved. So now our staff works just exceptions. It's a new value-added responsibility for them to improve the quality and accuracy on our front end. Our radiology processes also had significant improvements. We went live with radiology in 2 phases. We had 2 areas using it, and they're both housed within our Marshall clinics. So the first area went live in January of this year. Our second area went live in February of this year. We expect to do about 15,000 registrations for those 2 areas using OQM. The process to update the accounts that were created through the old registration process took about 2 to 5 minutes to update. Again, now, as soon as the order is released, the account is registered, and it's near instantaneous. So with that, we project to save almost 900 hours in a 12-month period. Orders are available with every OQM registration, and allows the staff to also focus on the exception-based workflows for value-added activities, not just busy work trying to run through papers. Okay, so we had great successes with labs and with radiology. We had another area approach us about using OQM for their work. Our clinic billing office handles the professional and technical fees for our patients. So they had to go through and determine if they had to create new accounts or if they had to use an existing account to supply those charges. So we had an in-house application that was built that allows them to recognize patients that met 72-hour rules and 24-hour rules, the appropriate requirements for them to determine whether or not a new account was required. We layered the OQM technology on top of that application, and then once that determined that a new account could be created, they just pushed a button and the registration was created, matching up the correct patient information from MDM and setting up all the demographics the way the registration should populate. So we started doing that actually on Valentine's Day this year, and we project 61,000 registrations to be completed in 12 months using this process. Their requirements for completing a registration were a little different than what our main registration was. But their old process took 15 seconds to a minute per account to complete. And now, again, once they push that button, it's an almost instantaneous account generation. And we're anticipating saving almost 600 hours a year just for this small department. Now, before OQM, the staff had to process so many accounts, they did not have the ability to take on the quality and accuracy components of their registration. They were just churning through those just to get them set up. Now, with the exception-based workflow, they have time to work our registration quality work queues so that they can make sure that those accounts are the best quality. About 75% of accounts we create don't require any intervention, but 25% do. And with the new OQM process for this department, they were able to really focus on what mattered and improve their accuracy rate to 95%. This slide just demonstrates the amount of accounts that we create through OQM since we started. The blue bars represent our lab registrations and orders. And that means we had a registration created, sent to Affinity, and our orders and the order documents. Those are two separate things. The orders and order documents went to Cerner and Soft Lab. The red bars, starting this year in 2017, the red bars represent the radiology accounts. The radiology just completes the registration right now, and it sends a textual copy of the order over into Cerner. And then the green bars represent our clinic billing account that we've created. Our CFMC is the service for those types of accounts. There's our clinic billing account, and that's just creating registrations. There's no orders tied to those particular accounts. Currently, we've got a few more projects in progress with OQM. We're working on getting pediatric echoes and registrations and echo orders sent downstream. This is using an existing workflow, but it's a new order type for us, coming in electronically. So we're working on that. We're working also on the Cancer Center lab orders. Those are sending similar orders, but it's using a brand new order source. These will be coming from Varian now to create those orders. And then we're going to be using our existing account numbers for those patients. These are series account patients, so we're going to develop that logic. On our roadmap for OQM, we want to get our radiology scheduled visits in place. Right now, we're just working on radiology walk-ins. These radiology scheduled visits would show us, it would use the existing orders that we're already receiving, but it will create a new workflow. These will be like pre-registration visits for us, so we can do all the work prior to the patient arriving for service. We want to make sure that we are able to send the actual radiology orders downstream, not just a textual document. And and that's sending those orders into a new system. That's into our PACS system. We're working on the cancer center radiology orders. That is a new order type from a new order system using the existing workflows that we have today. And then recurring visits for our rehab services department, we want to start using a different kind of fee. We want to use our scheduling fees to help us manage it. And those scheduling fees would come from Cerner, which is new for us. We will utilize some new account number tracking logic for those accounts as well. And finally, we have endo and surgery pre-regs and orders. So that is something we're trying to get new types of registrations created and new types of orders created through OQM. We have a lot going on. It's very exciting times for us here at Cabell. So, with that said, thank you for letting me share our story with you. Does anybody have any questions?
All right. Thanks, Lisa. Let me go through and look at the questions that have come in so far. It looks like we have a couple of questions that have come in at this point. So, first off, are order results mapped back to the provider directly, or is it just to the patient record?
So we have them in the patient record, but it also goes all the way back to all scripts where the order originated from. There's an identification number that flows all the way through the system and allows that result to be tied to that exact order that the physician wrote.
Looks like another one's come in. So in our hospital, we have a lot of orders that change after time or get canceled. How does OQM process those kinds of events?
Okay. Well, that's a very good question. So we had those same concerns. OQM always receives the latest and greatest version of an order and keeps that at the top, keeps that most readily available for the patient. So if a physician writes an order and then later cancels it, that order will no longer be available in OQM. If they write the order and they make adjustments to it, then that most recent version will be available in OQM. OQM has a wonderful tracking tool where it tracks the status of everything. We also have instances where a provider will, in our radiology department, this is common, a provider will write an order for a left knee, and then the patient comes back into the room, they get ready to get on the table, and they realize that the order should be for the right knee. Before services are rendered, we can get that correct order from the physician's office. When they make that correction in their system, OQM automatically receives it, and then we have a correct order available to process.
Excellent. All right, here's another one that's come into chat. How does this tool work with scheduling?
We are just exploring that. We use a scheduling feed for our clinic billing. It recognizes, it tracks when the patients arrive, it tracks when the patient is in the clinic and actually has services rendered that day. We are looking at using it for our rehab visits, and through our initial discussions, OQM will track when the appointment's made. It'll watch when and monitor when it's coming time for the appointment to see if adjustments have been made to it. It'll monitor when the patient has actually arrived on the facility for their visit, and it'll track if it's been rescheduled and or canceled. So we'll have that latest and greatest information available through that scheduling feed and in OQM.
Okay, excellent. Just a couple more that have come in through private chat here. Did you find that there were some departments who were reluctant to participate? Because with all of this automation, it seems like some people's jobs might be in danger.
We did have some reluctance. However, our volumes were rapidly increasing and the staffing was not increasing. So what this actually did for us, it allows us to have staff focus on really value-added steps rather than busy work. It has not reduced any staff at our facilities at all. And I think people are understanding we want to do the work on the front end rather than the back end. It's just shifting where the work is at.
Excellent. Can you tell us more about the textual order that is sent? How is that viewed?
So the textual order, we have it stored in what we call our physician documents in our electronic record. And that textual order just takes the electronic language that comes across and formats it in a way that end users are able to view it and understand it. It looks very similar to the way a paper order would show up. And because it's in that textual format, our coding tool can read it, and you'll see me putting quotes around it. They can read it easier. It's easier to handle than optical recognition, maybe some messy handwriting, those things. So the textual document goes across and gets placed in a folder in Cerner. The actual order goes across and gets placed under the Orders tab in Cerner so that the work actually can be performed against it. But that textual document kind of serves as a source from the originating system. Does that make sense?
Okay. Let's see, a follow-up to that. If I am understanding correctly, it's released from OQM and then an account is created. Do the orders go to a queue in your scheduling system? And how do you get them onto the schedule from OQM?
Right now, we are just using OQM for our walk-in patients and the specimens that present. We are in the process of developing OQM for those scheduled encounters. So we're still fine-tuning that logic.
Okay. And here's a good one. Will a textual order cross when another order might get stopped for reconciliation of codes?
No, they will not. The orders that the textual orders that cross are ones that we are able to process through OQM. So if there is an error processing it through OQM, it should not cross.
Okay. Let's see. Any last questions coming in?
This is Terry Jackson. Can you hear me?
Yeah, we can hear you, Terry.
All right. I would like to ask some questions around centralized scheduling and sending orders over for scheduled procedures, such as cath lab, specials, or maybe even in the surgery or minor surgery areas. Orders such as patient status or something like that. Have you all thought about or experimented with any of those?
That's what we want to work on as part of our endo and surgical implementations. We are trying to make sure that we've got the order compendiums lined up, and we are right now working through getting our order catalog from the surgical areas in alignment with what the physician office's orders. We had a disconnect there, so we're getting that lined up first. But yes, we expect to be able to create pre-regs, tie them to that particular account, when the patient presents for service, be able to move forward with that whole process.
Have you found any limitations in this tool in aiding you to put those type of workflows together?
I really, honestly, have not found any limitations. This is an extremely, extremely flexible tool. And so what we have done is we've come across an issue, okay, we think there's some automation opportunities here. We have these kinds of information available. And then we work with our solution architect and try and develop a new process. And so far, I haven't seen anything that would stop us. As long as the data is available electronically, we've been able to accomplish what we've asked.
Okay, thank you.
All right, we've got room for a couple more questions. Did anyone else have a final question to ask? right, one last one came in to me. Just to clarify, did you have MDM implemented before you started on this journey with OQM?
Yes, we did. We did not have a way to identify the patients as the same across Marshall and Cabell campus until we did that. So our first step was to get the MDM implemented.
Okay, and one more here. Is the OQMQ monitored and processed manually as needed? So do you go into OQM and just kind of manually keep a monitor on things, or is it as patients visit?
Right now it's being done as patients visit. We do have an option to, as the orders expire, then we can get that information and clean that up. We have not yet done so, but we have that option to do that.
And in terms of order reconciliation?
In terms of order reconciliation, if an order is processed through OQM, then we can see it and we can track it back through OQM. And then that's what ties the results back together. If we process something outside of OQM, then it may show up as an unsolicited result in the provider's EMR system. But using OQM, we can tie everything back together, and the provider can see if the test is outstanding on his or her side.
And if you have a patient who maybe forgot to fast or wasn't really prepared for all of their tests, can you do partials? We can.
We can absolutely do partial testing. Sometimes the test isn't able to be tolerated by the patient as well. So we are able to release what we can do. If we can't do any of it, and we thought we could, we can unrelease them and make them visible again if necessary.
Tyson, this is Deanna. I did want to interject back to regarding the release process. So here, the lab, and radiology resources are, reviewing and then releasing the items in the queue as the patients walk in. But we do have other implementations for customers where we have set up the workflow to be based on a certain amount of time. It could also be based on, another type of event or transaction that, is made available to OQM. So there is a lot of flexibility in that process, kind of based on what, how the organization wants to do it.
Thank you.
Excellent. Well, without further questions, let's do a final recap here, and I will pass things over to Deanna.
Yeah, so as we just wrap up, I just wanted to leave you all with a list of questions you could take back within your organization if you want to determine if OQM might be right for you and your organization, either based on problems that you could be encountering, within the lab or within the labs on your side, or, from perhaps complaints or issues with providers. So, one of the first items to consider is whether or not the providers that you work with are continuing to print and fax orders, even though you do have the ability to electronically accept orders. Have they given up on that process because of the challenges? And if so, that's something to, take a look at to say if you could improve that process and guarantee that the orders can be loaded, you can kind of regain that efficiency. Does your lab staff need to re-register clients when they show up for their visits? Or do you, in the cases where you already have seen them before, or information about them from other departments, could you potentially reuse that and create the registration for them? Do you experience delays because the systems throw exceptions when you're loading an order, and you have a patient standing there waiting for things to be re-entered, or having to call back to the doctor's office to try and find out exactly what the order is for? If there are complaints about those types of things, OQM can help alleviate some of those challenges. Are the results getting sent back to the patient's record in the EMR? Are you getting calls, to your lab department saying, where is this result? We can't find it. Can you resend it? Can you go ahead and fax it? Evidence of those types of issues. OQM can help make sure that the result has the information it needs to get back to the EMR. And then also take a look at the billing process and the potential impact of any of these issues on perhaps billing for the wrong test or code, or having issues with reconciling in fact what was ordered and what needed to be billed, to see if there's a number of items that perhaps are not being covered. Some of the challenges within this process could be contributing to those issues, and streamlining that process can definitely help alleviate that. So with that, we're going to wrap up our presentation. So thank you so much to everyone for attending today. And if you have any other questions or you want to learn more about OQM, pardon me, I'm sorry, my mouse is, there we go. You can go ahead and contact Jim Daphnis or John Wheeler. We have their emails there on the slide. They're pretty easy to remember. It's jim@imt.ca or john@imt.ca. You can also contact me as well. I'm Deanna at imt.ca. Also, if you visit our website, we also have some videos that talk a little bit more about this solution, show it in action, as well as some other product literature. So we look forward to hearing from you about this, and if you have any other questions or want us to talk further, please don't hesitate to reach out to us. Thank you so much.
Thank you, everyone, for joining us today. This concludes today's webinar.